Hello, I'm Bryony Dean Franklin, and I'm one of the theme leads within the NIHR Imperial Patient Safety Translational Research Centre. For this World Patient Safety Day, which focuses on medication without harm, I'd like to explore just what we mean by medication safety, and I'm going to illustrate this with some of the research being done in this area across all three of the NIHR-funded Patient Safety Translational Research Centres within England. So what do we mean by medication safety? I've sort of grouped this into three main areas. First of all, avoiding adverse drug reactions or side effects, which in some ways is the domain of drug development and formulation. Secondly, avoiding medication errors, which by definition are preventable and may occur when a medication is in the hands of a patient, a carer, or any healthcare provider. But by definition, these are preventable issues. And thirdly, we can think about optimizing use of medication by the patient. So this will include things like optimizing things to improve adherence to a prescribed treatment. Now, all of these are important and all form part of medication safety. But within the scope of this presentation, I'm going to focus largely on avoiding medication errors. So let's look at this in a bit more detail, including why this is so important. Well, first of all, medication is the most common healthcare intervention. Nearly every patient admitted to hospital will be prescribed at least one medication during their stay. And in one of our studies, in a random sample of many thousands of patients who are registered with a GP, 68% received at least one prescribed medication during the previous year. And these sorts of figures don't include over-the-counter medicines that are purchased by the patient. Medication use also spans all areas of healthcare, both hospital, specialist areas, primary care, patients' own homes, and affects nearly all healthcare providers. Errors, unfortunately, are common, and I'll give some figures on those in just a moment. Now, the vast majority of errors, fortunately, do not result in patient harm, but some do and are potentially serious. So let's just flesh those out in a little bit more detail. Various systematic reviews have been done looking at how often errors occur. So just to give a few examples here, a study by Lewis et al. From Manchester, which suggests that prescribing errors occur in 7% of all doses given in the inpatient setting, affecting 52% of all patients. And administration errors occur in about 8% of doses in another systematic review by Richard Kears. With that figure being much higher if we look just at intravenous medication. It's estimated that about just over 4% of all admissions to hospital are drug-related and preventable, and that 1 to 2% of all inpatients suffer harm due to medication errors. So what did the WHO do in response? So in 2017, the WHO announced their third Global Patient Safety Challenge, which focused on medication without harm. This set the goal of reducing avoidable harm due to medication by 50% by 2022. And they highlighted these four domains for intervention: patients and the public, healthcare providers, systems and practices, and the medicines themselves, which might include things like how medicines are packaged and labelled. The WHO also suggested three priority areas for action: transitions of care, whether this is between healthcare sectors or between individual healthcare providers, high-risk patients and situations, and polypharmacy, which is where patients are prescribed a large number of medicines. And of particular concern is inappropriate polypharmacy, where patients are prescribed far more medicines than is strictly necessary. So let's illustrate this with some examples of research from across the three patient safety translational research centres. First of all, this is some work that focuses on patients and the public in terms of an intervention. It's some work that we did here at the Imperial Patient Safety Translational Research Centre, and we looked at how patient-held lists of medication can enhance medication safety. We conducted focus groups and interviews, and also a quantitative study of what sorts of information patients carried and the characteristics of the common tools that patients used. We found a great many examples from both patients and from healthcare professionals of how patient-held lists of medicines had been really helpful in preventing harm. Interestingly, though, patients often didn't realise that this could be quite helpful. I think there's often an assumption that in one national health system that all healthcare providers would automatically have access to a full and up-to-date list of patients' medicines. Now, while we are now much more connected in the NHS than we ever have been in the past, it's still not guaranteed that any one list can include all medicines that somebody's on, particularly if they're having medication from specialist clinics or purchase things over the counter. This work also drew on substantial contributions from lay partners providing patient and public involvement, and the paper that I've shown here has 5 authors, of whom are our patient involvement partners. Before moving on, for those of you listening who are clinicians, I would really encourage you to encourage your patients and carers to carry information about their medicines. The patient is the one common link in the chain when they transfer between healthcare sectors and different providers. And it's also helpful to ask patients if they carry a list and show them that you find it helpful and value it in order to encourage patients to play an active role in their care. Another example, moving on to an intervention based more at the level of healthcare professionals and also systems and practices. This focuses on the use of barcode medication administration in the hospital inpatient setting. Now, a number of studies have shown that using barcode scanning of both patients and their medicines can reduce errors, and yet often scanning rates are not that high, even where these systems are in place. So we're doing some work at the moment working with a large local NHS trust to explore the barriers and facilitators to the use of scanning. I've put here on the slide some of the work that we've done, mapping those barriers and facilitators onto the COM-B behaviour change framework. And we're now in the process of testing some behaviour change based interventions to improve scan rates. And a final example from our centre focuses on prescribing errors and providing feedback to hospital prescribers about their errors. This was work based on the finding that hospital prescribers often didn't know when they had made an error and therefore were unable to change their practice. So we did a 3-part intervention focused on increasing rates of prescriber identification, training up pharmacists in how to give feedback in a really supportive way that made sense to the recipients, and also a prescribing tip of the fortnight highlighting a common or potentially serious error. And there's an example of one of these shown on the slide. We found that this reduced prescribing errors and increased prescribers' awareness of feedback. This system is now in use in several NHS trusts. This is an example from the Greater Manchester Patient Safety Translational Research Centre that also looks at feedback, but this time in primary care. The paper that I've included here on the slide describes the development and evaluation of an intervention with various components looking at training clinical pharmacists in delivering an intervention to GPs, which comprises a web-based dashboard giving actionable patient-level feedback based on a whole series of indicators of higher risk prescribing, and also training up pharmacists to review individual at-risk patients and either make the changes or ask their GPs to do so. This study showed a reduction in potentially hazardous prescribing by 41% after 12 months. And as a result, this intervention is now being rolled out across Greater Manchester's 3 million population. And a final example comes from the Yorkshire and Humber Patient Safety Translational Research Centre. And this looks specifically at harmful prescribing in older, frail people with a focus on the anticholinergic burden of the drugs prescribed. So this is again focusing on healthcare professionals and the systems and practices as well as the individual medicines used. In this study, the researchers developed a multi-part intervention, including an invitation letter to patients to attend for a structured medication review, a patient-held document, and other resources to help with this intervention, which is now being evaluated. So, having given a few examples of work in this area, I'd like to end with these three thoughts. I hope I've illustrated the relevance and importance of doing high quality research, not just into medicine development, but in how they are used in practice and how we can use them safely. I'd also like to highlight the importance of end user involvement in such research, whether this is patients and the public or the healthcare providers who will be involved. And all of the examples that I've presented here include substantial end user involvement. And finally, how important it is for all of us to translate the findings of research into practice so that we can truly work towards a situation where we have medication without harm. Thank you for listening.